Hello everyone, and welcome back to This Week in Pulmonary and Critical Care Medicine. I know your days are packed, so the goal here is simple. A clear run-through of a few important studies that might change the way you practice, plus one review article you may want to keep close for reference. This is strictly educational, not medical advice. In today's roundup, we'll look at whether non-invasive ventilation really needs a hospital bed to get started, whether dialing up PEEP to chase a lower driving pressure actually changes outcomes in the operating room, and what happened in the largest sham-controlled trial of COPD denervation. We'll wrap up with a fresh review on intrapleural fibrinolysis and why we may be measuring the wrong things. This first paper comes from Thorax and tackles a very practical question. In patients with neuromuscular disease or restrictive thoracic disorders who need non-invasive ventilation, do we really have to admit them for initiation, or can we start therapy at home or in clinic? The investigators performed a network meta-analysis of 8 studies, 5 randomized controlled trials, and 3 prospective non-randomized studies. Altogether, 350 patients were included, 144 who started in hospital, 119 at home, and 87 in outpatient clinics. The most common outcome measured was daytime PaCO2, standardized to about 6 months of follow-up. The authors defined non-inferiority as within 0.5 kilopascals of PaCO2 reduction compared to in-hospital initiation. Both outpatient and home initiation met that bar. PaCO2 fell in all 3 groups, and the differences were clinically negligible. Interestingly, when they ranked probabilities of effectiveness, both home and outpatient pathways actually came out ahead of hospital initiation, although the certainty of evidence was rated low using grade. Secondary outcomes, things like partial pressure of oxygen, bicarbonate levels, adherence to therapy, and quality of life scores, were all comparable across groups. Adherence, which clinicians often worry about with home initiation, was not inferior. So what does this mean in practice? If you have a patient who is clinically stable with reliable home support and access to respiratory therapy follow-up, it is reasonable to start NIV outside the hospital. That could mean outpatient clinics or directly at home with proper telemonitoring. Of course, certain patients, those with bulbar dysfunction, high secretion burden, or significant hypercapnia, may still need inpatient initiation. But for many, this study supports what we already sense clinically. The hospital is not always required. This evidence should embolden programs to set up structured outpatient initiation pathways. The caveat is that protocols and rapid troubleshooting systems must be in place. This isn't a set it and forget it situation, but it opens doors to more patient-friendly, cost-effective care that doesn't compromise outcomes. Now to the operating room with the IMPROVE-2 trial. This was a large, multi-center, pragmatic randomized controlled trial published in Intensive Care Medicine. It tested a simple but important question. If we titrate PEEP in real time to keep airway driving pressure, which is the difference between plateau pressure and PEEP, under 13 centimeters of water, can we reduce postoperative pulmonary complications? The strategy was straightforward. After a recruitment maneuver, PEEP was increased stepwise in 1 centimeter increments until driving pressure stayed under the threshold. The control group received standard protective ventilation with tidal volumes around 7 milliliters per kilogram and fixed PEEP of 5 centimeters of water. The physiologic results were dramatic. The intervention group had a median PEEP of 15 compared with 5 in controls. Driving pressure dropped significantly and respiratory system elastance improved. Essentially, the lungs looked happier on the ventilator with this approach. But when it came to outcomes, the trial was neutral. Rates of postoperative pulmonary complications were similar between groups. Mortality, length of stay, and other patient-centered outcomes did not improve. The editorial accompanying the trial provides insight. First, it reminds us that driving pressure is an attractive physiologic marker. Observational data clearly link higher driving pressures to worse outcomes in ARDS in surgical patients. But treating a marker is not always the same as treating a mechanism. By raising PEEP to lower driving pressure, you may be preventing collapse in dependent regions, but simultaneously over-distending others. The lung is heterogeneous, and airway pressures are an imperfect reflection of what's happening regionally. Second, the editorial points out that perioperative complications are multifactorial. Ventilation strategy is one piece, but surgical insult, fluid management, analgesia, and patient comorbidities play equal roles. Even a large change in mechanics may not be enough to move the needle if those other factors aren't addressed. Finally, there's a cautionary note. Higher PEEP isn't benign. In IMPROVE-2, mean PEEP in the intervention arm was 15. That has hemodynamic consequences: lower venous return, possible hypotension, and potential for increased fluid administration. It may be that the physiologic benefits were counterbalanced by cardiovascular downsides. So how should we use this? For me, driving pressure remains a helpful risk marker, but not a target to chase in non-ARDS surgical patients. Stick with low tidal volumes, avoid unnecessary oxygen, and consider individualized PEEP, but don't blindly push PEEP just to reduce the driving pressure. IMPROVE-2 is a reminder that protective ventilation is nuanced, and one-size thresholds may not apply outside ARDS. Next is COPD. Targeted lung denervation, or TLD, uses radiofrequency ablation to disrupt parasympathetic nerve input to the bronchi. The idea is to reduce cholinergic tone, improve airflow, and cut exacerbations, without relying on inhaler adherence. AIRFLOW-3 was the definitive trial, randomized, double-blind, sham-controlled, and the top-line result, published in the Blue Journal, the trial did not meet its primary endpoint. Earlier phase studies had shown safety and even hinted at reductions in exacerbations, but this larger, rigorous test just didn't replicate that. We don't yet have every subgroup and secondary endpoint teased out, but the main message is clear. Targeted denervation is not ready for clinical practice. For clinicians, that means we stick to what works. Gold-based inhaled therapies, pulmonary rehabilitation, vaccination, and comorbidity control remain our main tools. Devices like TLD may still find a place if secondary analyses show strong signals in specific subgroups, perhaps frequent exacerbators with certain phenotypes. But for now, this remains investigational. The investigators deserve credit for doing this the right way. Sham controls, blinding, the works. Procedural innovation in COPD is exciting, and it's tempting to want a breakthrough here. But without clear patient benefit, it belongs in trials, not in practice. Finally, a review in chest that re-examines intrapleural fibrinolysis. Despite widespread use of TPA, often combined with DNase, too many patients with complicated parapneumonic effusions or empyema still end up needing surgery or staying long in hospital. The authors make 3 key points. First, our trial endpoints may not capture meaningful success. In MIST-2, combination therapy improved radiographic clearance by about 30%, but most of the effusion was still present and hospital stays were not dramatically shortened. Imaging changes don't always equal clinical resolution. Second, we lack validated tools to predict which patients will fail fibrinolysis. Rapid scores predict mortality, not surgical rescue. Biomarkers like SUPAR and PAI-1 are intriguing but unvalidated. A small score combining loculation burden and split pleurosign showed high sensitivity and specificity for predicting surgery, but it's single center and needs replication. Third, the future may lie in precision fibrinolysis. Functional assays of clot lysis or plasmin generation could identify patients who fail therapy due to excess inhibitors like PAI-1 versus those who simply lack plasminogen. That opens the door to tailored regimens, such as supplementing plasminogen or inhibiting PAI-1 in non-responders. For now, the bedside takeaway is to manage expectations. TPA and DNase are not magic bullets. Watch closely for clinical improvement, fever resolution, chest tube output, mobilization, and consult surgery early if patients stall. My own view is that we need to stop treating fibrinolysis as one size fits all. This review shows us that biology matters. In the next few years, I suspect we'll see biomarker-guided fibrinolysis trials, which could transform how we treat pleural infections.
And that's our roundup. If this helped, share it with your team. It's one of the easiest ways to spread the evidence where it matters. And let me know which papers you'd like covered in future episodes. I'll see you next week.